بدي تريننج You can just type your details, your names, your country, and your email address on YouTube, and we will communicate with you to forward to the certificate. I hope you enjoyed tonight. I hope it is valuable to you. I'm sure you will enjoy your details, your names, your country, and your email address. Stay with on YouTube, and we will communicate with you to forward to the certificate. I hope you enjoyed tonight. I hope it is valuable to you. I'm sure you will enjoy your details, your names, your country, and your email address. Stay with on YouTube, and we will communicate with you to forward to the certificate. I hope you enjoyed tonight. I hope it is valuable.
Hello everyone, I'm Dr. Yasser Gohari, ICC President 2020. On behalf of the ICC founders and ICC boards, I would like to welcome you all in our Pharmaceris ICC Middle East webinar. And I would like to invite you as the speakers in our conference in next September from 16 to 18 and welcome you all in Egypt. Thank you.
Bismillah ar-Rahman ar-Rahim. Dear doctors all over the Middle East company and all over the world, I'd like to welcome you all in this night webinar with the Pharmaceris company. Today we will have some interesting lectures, one of them about facial pigmentation, which I will go through within few seconds. This webinar and sponsored by Pharmaceris, and I'd like to thank all members in the company for sponsoring for this webinar. ICC Group will be chairing this webinar in three of our doctors. With you, Dr. Mohammed Al-Khalawani and Dr. Wael Saudi and Dr. Yasser Al-Gohari. So I hope to enjoy this webinar and our interesting lecture this night. About facial pigmentation, I'd like to enhance about some points about an innovative clinical, pathological, and therapeutic challenging spectrum. This spectrum is about what we should have about the facial pigmentation. Facial pigmentation is one of the common problem, and we will see now about the slides. I am Dr. Mohammed Al-Khalawani, the professor of dermatology and dermatopathology and head of dermatology department in Al-Azhar University, Cairo, Egypt. Facial pigmentation, as we see, is it a medical or cosmetic problem? If you see these pictures, we have some of them. We can diagnose it as lentigines, we can diagnose it as melasma, as some lichen planus, some lichen planus pigmentosus. However, it may be a medical and it may be also as a cosmetic problem. Now, how problem is important? Is it important? This facial pigmentation is an important issue? Yes, it is important. Why? Because dyschromia is a growing concern and a top chief complaint when patients present to a physician. And persons of color, which is ethnic group, will soon comprise majority of international and domestic populations. Did you know in United States by 2050, nearly one half of the US population will be non-white. So we have a concern about the coloration of the face. Now, facial pigmentation, we should first of all to understand what is our problem. What is our problem of facial pigmentation? We will go through a few slides. Number one, the melanocyte is a concerning cell about the melanin pigmentation. So our pigmentation comes from the melanocytes, and the melanocytes started to synthesize melanin, and this melanin started to distribute upward. Take care about this one. It will distribute upward to the keratinocytes. So the pigmentation already in our population is epidermal pigmentation, starting from the basal cell layer to the keratinocytes up to the granular layer in some cases. So I have two different colors, the white color and the dark color. If I go through the white color, I will find the basal cell layer, as we see here. This basal layer is devoid from melanin pigmentation. So I have no melanin pigmentation here in this basal layer. While in the other slide with the dark skin, I have increased the melanin pigmentation, which is normal in dark colored persons. Okay? So when the melanin started to be in the dermis, like in the papillary dermis or upper reticular dermis here, so I have here some sort of melanin incontinence. That means the melanin started to go down from the epidermis to the dermis, and this we called melanin incontinence. After some time, the melanin started to be engulfed by macrophages, and at this time we called it as melanophages. This melanophage is a constant cell, so it will reset in this place for a long time. That means I have now some sort of dermal pigmentation. Okay? So the dermal melanin and the dermal melanophage sometimes associated with some reaction. This reaction may be vascular reaction, like in this color, as we see, dilated blood vessels here like this. This is a vascular reaction. And maybe at the second slide here is that inflammatory reaction. So I have maybe an inflammatory dermal pigmentation. So now I can categorize my pigmentation into three categories. What are these three categories? Number one is epidermal pigmentation. Number two is dermal pigmentation. Number three, it is dermal pigmentation associated with inflammation. So I have here three patterns of facial pigmentation. So when I deal with a case of facial pigmentation, number one, I should categorize this case. Is it epidermal, or is it dermal, or is it an inflammatory pigmentary disorder? Because each one of these subtypes should have a spectrum for management and spectrum for diagnosis. Okay, how to diagnose such a case? Now we go through how our assessment tools for the diagnosis. I have three important tools I should know about, and no case of facial pigmentation should be diagnosed or should be examined without these three clinical tools. The first one is the Wood's light, and Wood's light is one of the important diagnostic tool that can differentiate between epidermal and dermal pigmentation. When I have epidermal pigmentation and the color of Wood's light started to exam, I have accentuation of the color. This is number one. Number two, the dermoscopy. Dermoscopy, one of the diagnostic tools now to differentiate between epidermal pigmentation and dermal pigmentation. In epidermal pigmentation, I have a scattered islands of brown reticular network with dark fine granules, while in dermal pigmentation, there is uniform skin involvement and no area of sparing with this dark brown, gray, hyperpigmented lesions. So the dermoscope now is one of the good assessment tools to differentiate between epidermal and dermal pigmentation. The third assessment tool is the skin biopsy. And skin biopsy is very important in differentiating between dermal and epidermal pigmentation in one side, and in the other side, this inflammatory pigmentation. So epidermal pigmentation, dermal pigmentation, inflammatory pigmentation, I should differentiate between the three categories. If you suspect a case of inflammatory facial pigmentation, you should have a skin biopsy at this case. So now, what is the innovative spectrum that we called about? The innovative spectrum is facial pigmentation. We can categorize according to the anatomical side into three categories. Number one, the facial, which is the common, maybe periorbital, and maybe perioral. This is the three anatomical classification for facial pigmentation. But the three components may be at the same time, maybe at the same disease, maybe at the same patient. So the most important for us is the facial pigmentation. Is the clinical spectrum for this one is epidermal pigmentation. I have facial pigmentation with increased basal melanin pigmentation. This is what I concern about every time. This is the landmark for me. The dermal pigmentation, that means I have dermal pigment and melanophages in the upper part of the dermis and in the papillary dermis. And number three, the inflammatory facial pigmentation, which I have some inflammatory process according to the classification of this inflammation. So the spectrum now is categorized into epidermal, dermal, and inflammatory pigmentation. Number one, the epidermal pigmentary disorders. Epidermal pigmentary disorders, and I categorize this one, all the coming diseases will be diagnosed as epidermal pigmentary disease. That means I deal with facial pigmentation due to increased in the melanin pigmentation in the basal cell layer, or maybe above, but not down, not in the dermis. I will go through some common examples for this one. Melasma epidermal types is one of the common causes of epidermal pigmentary disorders, predominantly affected Fitzpatrick skin phototype 3 and 4. This is very important for us. Exacerbating factors may be such as hormonal therapy, pregnancy, contraceptive pills, and so on. Clinically, there are light to dark brown patches, maybe in the forehead, in the cheeks, in the nose, in the mandibular area, but in the epidermal type, the clue is the pigment is brown and the margins are geographic and more well defined, as we see in this picture. Okay. The second example is lentigens, and this lentigens is a common manifestation of sun exposure. Solar lentigens may be found in 90% of white populations, the common white populations, not like the melasma, and they are 3 to 2 well circumscribed, round or oval, irregularly shaped macules or patches. It's common in the face in light skin 1 and 2. Another example is to epidermal pigmentation is freckles or effluves, and this occurs in sun-exposed areas and may be also in the dorsal aspect of the hands. They are about 1 to 3 millimeters, well demarcated and hyperpigmented patches, and all of us know these freckles as a common presentation in fair skin. Maturational dyschromia is one type of pigmentation. This pigmentation may be categorized clinically as diffuse hyperpigmentation, usually in dark-skinned persons, and can be seen in mature dark skin. May be occurred due to sun exposure over time, and usually it is be present in elderly patients. The Rhine melanosis is one, we called it as a pigmented contact dermatitis, is characterized by brown-gray color, typically preceded by mild erythema and pruritus, followed by diffuse or reticulated hyperpigmentation, and this is also common in dark-skinned individuals, type 3 and type 4. And the favorite site for it is due to cosmetics, and the diagnosis is associated with closed patch test is very important in these cases. Acanthosis nigricans, one of the epidermal pigmentary disorders also, which characterized by hyperpigmented velvety plaques and asymmetrical distributions, and commonly appearing as in the heterogeneous area, and commonly associated with some predisposing factors like insulin resistance and obesity. Erythromelanosis follicularis fasciae E. coli, one of the rare dermatoses, is come as pigmented coloration in the cheeks, and this pigmented colorations associated with some follicular papules. And it mainly affects the young middle-aged men with onset in adolescence, and usually associated with keratosis pilaris in the trunk. It is manifested as gradually progressive reddish brown pigmentation associated with telangiectasia and sometimes associated with follicular papules, which is the landmark for this case. This is some common examples for epidermal pigmentary diseases as we categorize these cases. And our concept in these cases is we deal with epidermal pigmentation. That means, for me, if you ask me, if you go through the diagnosis, is it important to diagnose these cases? Yes, but it will be different in the management? No. Because my concept in these cases, I deal with a pigmentary disorder concised to the basal cell layer and the pigment in the epidermis. So how to treat these cases and how to manage these cases? I will go through the 5 weapons we have for the treatment of some pigmentary disorders. Number 1, some general structures in the form of avoid of sunlight and avoid of triggers. The avoidance of sunlight with many tools as we see, but the most important for us is sunblock. And our company today, the Pharmaceris company, had a broad spectrum line of sunblock, and Dr. Yasser Gohri will go through these lines and what are the benefits for it and what is the most beneficial one for each group, for adults, for women, for sensitive skin, for pediatrics, and I will let him to discuss for this item. Number 2, skin lightening agent. Skin lightening agent, one of the common topical tool that we go through the facial pigmentation, and all of us use this one. Now we have millions of topical preparations for pigmentation, but what is the most common or the most important for us? We should go through the mechanism. I have many mechanisms through this whitening agent to go through. Like inhibition of tyrosinase enzymes, or inhibition of melanosomes, or inhibition of protease, some enzymes, or reduction of the melanosome transfer. Some mechanisms, these mechanisms, all of it go through, either it is concerned with the melanocyte itself, or the transfer process, or the senses of melanin in the cell. Okay, this is the compounds that we work about these mechanisms. I will not go through the details for this one, but The gold standard for depigmented agents or skin lightening agent is hydroquinone, as we know all. But the main problem is the hydroquinone alone is not effective as it goes through the combination. That's why the Kligman formula started to have a combination between hydroquinone, between tretinoin, and between dexamethasone. But they found that the use of fluorinated corticosteroids is more effective, and the use of twice daily is more effective than 1 day, and 3 weeks is the least important. But the main problem for this Kligman formula was the irritation. That's why we go about the modifying Kligman formula. I started to modify this formula to add some products to decrease this irritation, and at the same time to go through more potent products. This is one of the examples, and these examples will not end. In Pharmaceris, as we know, we have a broad spectrum whitening lines. This whitening line is starting from the cleansing care, from the day-night care, and from the vitamin C, and from the eye contour. This whitening serum, as we see, they have multiple components. These components have a triple or maybe tetra action, but as I see, all of you may go through these products, and you know how it effective. It is very effective for the triple action. This is number one. Number two, for the know-how of manufacturing. That means how the product to go through the transepidermal barrier and to go to the basal cell layer. Once the product to go through this mechanism into the basal cell layer, it will be more effective. So this is one of the major components that we will use next time. Chemical peeling is the third line, and this third line we not happy to see these pictures for chemical peel. So you should prepare your patient good, and you should maintain your patient after peeling. We have 3 types of peeling: the superficial peel, the medium peel, and the deep peel. So superficial peel is the one we can use it in treatment of epidermal pigmentation, but the medium depth is not recommended, and the deep peel is not recommended at all. The superficial peel, we have many types of superficial peel. We can use a TCE or glycolic or lactic acid and so on. Laser therapy is one of the major therapeutic outlines now, but you should know about this laser therapy 3 important factors. Melanin has a broad spectrum absorption, and the melanosomes have a short thermal relaxation time, and the longer wavelength penetrates deep. So the laser therapy is not so easy to have, because you can have some sort of such a pigmentation or such a scarring. That's why you should deal with laser therapy in an experienced physician. Don't go through laser therapy unless you are professional in laser treatment, to avoid such pigmentation like this one. The systemic therapy is a lot, like melatonin, like glutathione, like polipedium, but the most important nowadays is tranexamic acid. Tranexamic acid, one of the adjuvant therapy that we can go through the treatment in epidermal pigmentation. So our 5 weapons here is sunscreens, topical, whitening agent, chemical peel, systemic therapy, and laser therapy. If you go to the dermal pigmentary disorders, that I have melanin pigmentation in the dermis. Now I have a different category of melanin level. I have a melanophage, and this melanophage is very hard to treat according to our strategy that we will see now. Some sort of this, some examples like melasma, dermal type of melasma, like post-inflammatory hyperpigmentation, like exogenous ochronosis, and some sort of dermal melanosis like Horai nevus or nevus of Otta. All these categories or these diseases characterized by dermal melanin pigmentation. So when I go through treatment for these cases, with our 5 weapons, we will go sunscreen will be reduce the pigmentation due to its effect in the epidermal pigmentation only. And topical whitening agent, it will go through type 3 and type 4 only, because it will work against the basal pigmentation only. Take care about this. The chemical peel, superficial peel will not be effective. So I go through medium peel, but don't forget our advice for you that medium dips should be performed with great caution. The laser therapy, we consider it as the future for the treatment of dermal benign pigmentation. either it is maybe single device or maybe as a combination between two devices together. But don't forget also the challenging and should be used by experienced physician. The tranexamic acid, one of the adjuvant tool, as we see, maybe in the epidermal and may be also used in the dermal pigmented disorder. So the 5 weapons we have, we can use it in the dermal melanin pigmentation, but take care, it will be go through some modification. The third one is the inflammatory pigmented disorders like actinic and lupus and so on. The treatment in this case is the treatment of the disease, not as cosmetic problem. You should treat the disease, not the cosmetic problem. So the innovative spectrum can be with epidermal pigmentation, which the light will assist me. The dermal pigmentation, dermoscopy will be effective. The inflammatory pigmented disorders and skin biopsy will be crucial in this case. Okay, thank you very much, and I hope to summarize this category in this innovative spectrum, and I'd like to have any comments for you. Thank you very much, and see you inshallah bismillah. Thank you for Pharmaceris and for ICC Group.
Hello, dear colleagues from MENA area. I'm Dr. Wael Saoudi, Assistant Professor of Dermatology and Venereology and ICC Secretary General. I will take this chance to welcome you to the Pharmaceris webinar, and I would like to thank Pharmaceris for their invitation and their care for continuous medical educations for our colleagues in our area. And also I want to invite you all as a delegate or as a speaker, and please send us, if you want to be a speaker, your abstracts on the email, which will appear on the screen later. And finally, and want to start my lecture, can we delay aging? Aging, it is a normal process, but can we do anything to delay the aging or not? So this is my email, waelsaoudi70@yahoo.com. So please, if you want to ask me any questions, you can send it me right now, or Dr. Khalawani, you can send it, or Dr. Yasser Gohari. For any time, you can send to ask us what you want. So let's start from the basic, and I will go to the advanced later on. I will start from the scratch, the structure of the skin. As we know that the skin has 3 layers, epidermis, dermis, and subcutaneous layer. But let me ask you a question. As aesthetic doctor or cosmetology doctors, do you think that the epidermis has a role in the aging process or not? Is it important or not? It is 4 layers, as you know, the basal layer, squamous layer, granular layer, and horny layer. As you know that the epidermis is avascular, but it should be hydrated, and this is very important. How can it could be hydrated and it is avascular? You know that, and I say always that there is a pipes or a chalumeau to take water from under to up to the epidermis. How can we get this water for the epidermis? As you can see here, the barrier, it's called many names. It's called double-way barrier because it prevents water loss and prevent infection to enter. Also, it's called dead but function. Dead because there is no nucleus in the stratum corneum, but still functioning as a barrier. So it is very interesting area in our skin, and I want to discuss it in 1 minute. Let's talk about the stratum granulosum. We have 2 structures appear here. The lamellar bodies, which will leading to production of the lipids. It will appear in between the keratinocytes, and we have the keratohaline granules, which leading to production of the profilagrin, and the filaggrin will change it to by enzymes to the serine protease to filaggrin. So the filaggrin is very important. The filaggrin at this stage, at the end, at the stratum corneum, it tightening the keratin bundles. So it make it very tight because you are facing the environment. So you need a very tight barrier. So after doing its function, it gives you 2 remnants. One, which is called in the blue color here, the natural moisturizing factor, and this is responsible for absorbing the water from the dermis. So our dermis should be very well hydrated, very well containing hyaluronic acid. That's if you are working in aesthetic, we injecting hyaluronic acid a lot to keep hydration in the dermis, so the epidermis can take its hydration level. And after it changes to a natural moisturizing factor, it also gives an acidic media. So acidic media is very important for protection of our skin. So in diseases affected for filaggrin, if you can name the diseases affected with filaggrin, like ichthyosis, like atopic dermatitis, you will find 2 things: xerosis, and it will be a recurrent infection. Okay, this is very important to say because the epidermis is also, we should care not only about the dermis, but also the epidermis is very important. So, okay. Next slide. So the water is important to be content in the stratum corneum, and it should be 10% of the weight of the stratum corneum. So let's go to the dermis. Let's imagine that the dermis like water, and inside the water there is a fish. Exactly the dermis, the water is the gel, the hyaluronic acid. So you should keep the environment very healthy for the fish, like hyaluronic acid, so the fibroblast can continue doing its function, so it can produce a collagen and elastin. So if you want to keep aging away, or you want to delay aging, you should keep normal environment in your dermis. You should keep the normal functioning of the fibroblast to produce the collagen and elastin. So we will come to what we hate. We hate aging, but everything, in my opinion, every age has its beauty. Aging, there is a decreased maximal function and reverse capacity in all body organs, resulting in an increased likelihood of disease and death. So, unfortunately, we starting aging from day 0. So never tell your patient, just go, you are still young. You should working early on his skin to delay aging. There are two theories of aging. We know that there is intrinsic aging and extrinsic aging. What is the difference? Now, if you are 10 years, then become 20, 30, 40. This happens for everyone. We can't stop this. And the responsible for this is the telomeres. The telomeres, what is the telomeres? Telomer, as you can see in the slide, it is the end of the DNA. Its function during replication of the DNA, it prevents adhesion of the two strands. So it is only function, but not continuous of amino acids. But each cell cycle, we lose about 100 to 200 bases of telomeres are lost with each cell division. As you can see here, this metal part, if it is healthy, everything will be okay. If you lost, it will damage the cell. So there will come a time telomeres loses 100 to 200 amino acid, 100 to 200 amino acid. So the period it will lose the period which is called Hayflick limit. This Hayflick limit, it's the time our lifespan of the telomer. If the Hayflick limit ends, the cell cannot replicate again, and death and aging, of course. So there is a natural aging process leading to appearance of aging skin, continuous non-scarring process, thin, fragile, and finally wrinkled skin. And recently, the importance, it's not only the telomer. They found that the ROS, or oxidative stress, is responsible for stimulation of the telomer replication and leading to aging. So what's happening on our skin? Degeneration of elastin fibers, degeneration of the collagen fibers. As I told you in the dermis, this is the main function of the fibroblast. So now you are going to age and will be appearing thinning of the skin. So what is the second theory? It is the cumulative environmental damage, or extrinsic theory. The intrinsic theory occurs in everyone, but this is a burden on some people who are heavy smokers, who are outdoor workers, who are under stress, who are obese, all of this leading to aging rapidly. So the main cause is what's called photoaging. So these two photos of two sisters. On the left side, she's indoor, outdoor on the right side. So the big difference appear, the effect of they are the same age, they are twin. So the skin protected appear good skin, and the sun exposed appear aging, very aging skin. So we are going to our topic, what is photoaging. As you know that the pharaohs, they love to go to the sun. Akhenaton, this is a very nice story. Akhenaton built the temples which has no roof. He take his family, as you can see here, and his wife and his son, and stay in the sun to go benefit from the skin, from the ultraviolet and from the sun. But did he know that the rays has a harmful effect or not. I don't know. The spectrum of solar radiation is composed of 2 to 3% of ultraviolet, 32 visible light, and 66 of infrared light. Let's see the ultraviolet. The ultraviolet spectrum, I want to say that for our juniors, the ultraviolet spectrum from down to up, C, B, A, not ABC. Please follow me. UVC 200 to 920 and 290 nanometer, UVB 290 to 320, UVA from 320 to 400. Again, UVC, UVB, UVA 200 to 190, 290 320, 320 to 400. So what is the importance for that? These numbers is very, very important. If you are working for lasers, you know that there is a chromophore. The chromophore is the target you want to hit with the laser. That's why there are many types of lasers. Why? Because the chromophore absorb only the wavelengths specific for it. So what is the relation between the chromophore and the ultraviolet? The DNA inside the cells absorb the ultraviolet till 290. If there is absorption of the ultraviolet by the DNA, there will be change in the DNA and there will be hazards, especially for carcinogenesis. Okay? But thanks God that the ozone prevent the 290 and shorter lengths to go down to the earth. But we still mention 290 in the UVB. So the 290 number is very important because if it passes to the earth, it will be absorbed by the DNA, it will change our DNA, and it will be so dangerous and will lead to cancer. That's why the early sunscreens is only concentrated on the SPF, sun protection factor for the UVB, not concentrated on the UVA. But later they become broad spectrum after they know the importance of the UVA also and the hazards of the UVA. So if we look to this photo, it's very important. We see here the UVB will reach its tip to the dermo-epidermal junction and the early upper dermis, while UVA can reach down to the dermis. If I want to conclude in one word, the UVB will be responsible mainly for the carcinogenesis of the skin here, because it goes by heavy mainly on the epidermis, keratinocyte, and will be absorbed because it has a number of 290, as I said before, so it will change the DNA of keratinocytes leading to cancer. And UVA will go down mainly to the fibroblast. It will change all the environment we said before. It will change the dermis environment, leading to killing the fibroblast by many ways, which will be concluded later on. So that's why we said to our patient, don't go out from 10 a.m. to 4 p.m. Why? Because this is the time where UVB comes to the earth, but UVA comes from sunrise to sunset. UVB, that's why we should protect our patients during all the day with the sunscreens. Not only the ultraviolet, but also the infrared radiation has a very good relation to the photoaging. And now the sunscreens has a wide spectrum, ultraviolets and infrared and visible light also. Here we can see that the infrared radiation has three types: infrared A, infrared B, and infrared C. They have a warm or thermal effect on the epidermis. So they are very dangerous also, and we should protect ourselves from the infrared as we protect ourselves from the ultraviolet. The heating here mainly with the infrared C, it causes 100% epidermal thermal effect. But if we look to the infrared A, it passes to the dermis and causing 48 warmth of the dermis and leading to damage mainly and increased collagenase expression, and this is very important. Let's make a rapid revision about the effect of ultraviolet on our skin. You have 5 effects acute, 2 effects chronic. So if anyone asks you, you have 5 effects acute of the sun and 2 effects chronic effect on the skin. The first one acute from the 5th, the sunburn. Sunburn, it happens due to inflammation, vasodilation from the ultraviolet exposure. You should know 2 things in every one of the coming manifestations: which type of ultraviolet and what is the mechanism leading to this manifestation. The ultraviolet B is the main responsible for the sunburn due to angiogenesis. But it's very important to know that it leading to increased expression of nuclear factor kappa B. Dear colleagues, if you hear nuclear factor kappa B, you should know that there is a severe inflammation. So in dermatological disease, you see an inflammation, you will find a nuclear factor kappa B has a good effect. And there is 1st degree and 2nd degree burn. Also UVA can cause erythema with very much degree exposure. The second is tanning, and we have immediate tanning due to UVA. Here the mechanism is due to photooxidation of the already present melanin, but delayed pigmentation occur with the exposure of UVB due to new melanin production. The third effect from the acute effect of the sun on the skin is the increased thickening of the epidermis. 4th is the immunological alteration, and if we expose to the sun, we have a decreased or suppressor pathway will be stimulated. If you come from the beach, you find herpes, something like that, due to decreased immunity. Excision repair is very important because if, as we said, DNA is affected, so there will be excision, then repair by the and the ligation, and we will repair. This is very important for our health. So we will come to the chronic reaction. It is either the cancer or a photoaging. Cancer here, as we can see, occurs with time and with due to ultraviolet, including the increase H2O2, which will lead to very changes in the dangerous changes in the DNA, protein, and lipid oxidation, photoaging, and skin cancer. Also, the second manifestation is the photoaging. As you can see here, it is the effect of sun exposed. It occurs mainly at the sites of sun exposure. This is a very nice article for review article, what's called inflame aging. This is very important that they said that the conclusion, in the old age, there is increased inflammatory markers, which are not leading to the aging only, but leading to systemic diseases. This is very important. This happens as affecting the immunity of the old age. The old age adaptive immunity decline while the innate immunity is activated, leading to increase the pro-inflammatory inflammation. This is very important nowadays. Why? Because as you can see here, the inflammatory aging leading to all the disease occur with aging. This is very important nowadays, as they found that in old age, interleukin-6 is high. So as nowadays in COVID-19, they said if you have a high interleukin-6, you should go and give the anti-inflammatory for interleukin-6. So that's why it's leading to severe effect in old age, because they have inflammatory markers high. This term is called inflame aging, and this is very new. As you can see here, the stress and the factors and the inflammatory mediators, all of this leading to the inflame aging. I will set these slides, and please concentrate. I will take 2 minutes or 3 minutes in these slides. No one can no one can prescribe prescriptions except he knows this slide very, very well, because this will guide you in your clinic. So please concentrate with me. I will take only 2 minutes and 5 minutes. It looks difficult, but it's really easy. How can the ultraviolet light affecting keratinocytes and the fibroblast? This figure here, this is the fibroblast and keratinocytes. This is the cytoplasm of the fibroblast and the keratinocytes, and this is the nucleus. And this is the extracellular matrix. What's happening? Remember with me, the sun has 6 arms. 10. Again, the sun has 6 arms, leading to aging with 6 arms. So I should hit the 6 arms to delay aging. The first arm. As we said, we have UVB and UVA. Okay, what is the importance? Here in this first, sorry, I write here 6. So let's consider it number 1. There is a transforming growth factor beta receptor on the fibroblast. From its name, transforming growth factor. So if you stimulate this receptor, the fibroblast will produce the collagen and the elastin. So, of course, unfortunately, the sun will inhibit this receptor. So, if I want to prescribe an anti-aging containing growth factor, it will act on this receptor, it will help. The second line, as we said that the UVB containing number 290, so it will be absorbed directly by the DNA, leading to, this blocks is the DNA mutations. So it leading to DNA mutations in the fibroblast, leading to stoppage of the work of the fibroblast and cancer in the keratinocytes. So the second arm, direct effect of ultraviolet B. The third arm, as I said, nuclear factor kappa B increase, leading to the inflammatory aging, I said it before, leading to increased pro-inflammatory cytokines, which will calling or attracting the neutrophils, and they will produce matrix metalloproteinase 8, which is the collagenase, leading to aging. So let's reply again these 3 pathways. The responsible for it is the UVB. First, inhibition of the transforming growth factor beta. Please repeat after me. Inhibition of the transforming growth factor beta receptor, direct absorption by DNA, nuclear factor kappa B stimulation leading to collagenase production. Let's go to the other side, the UVA. UVA, it doesn't have number 290, so it will affect the DNA indirectly, not directly. Indirectly through the ROS, or reactive oxygen species. Reactive oxygen species, it will go to the DNA damage. It also will pass in this way to increase activated protein 1. Everyone should know what is the activated protein 1. Activated protein 1 is very, very important to prevent aging. Activated protein 1, its presence in normal level leading to increased pro-collagen. If it is increased, it leading to decreased collagen. So, thanks God, he put retinoic acid receptors to keep inhibition of the activated protein 1. So, unfortunately, again, the sun will inhibit the retinoic acid receptors, so activated protein 1 will be raised, leading to decreased collagen production, decreased matrix proteinase activity, and collagen breakdown, and leading to aging. So, this is the 6th arm you should repeat after me. Again, UVB has 3 arms and UVA has 4 arms. UVB inhibit transforming growth factor beta, UVB direct absorption to the DNA leading to DNA inhibition, UVB increase nuclear factor kappa B because they have direct effect. UVA, yes, indirect effect leading to increase in ROS, and the ROS will leading to inhibition of the DNA. ROS will go in a long pathway leading to increase in activated protein 1. The sun will leading to increase the 2 compartments, C-JAN and C-phos, leading to increase in activated protein 1. The UVA will inhibit retinoic acid receptor, leading to activated protein 1 increase, and this will lead to aging. So, how to pass? If you pass, you can pass, you will delay aging. So you should attack all the 6 ways of aging. So you are never too young to start prevention. The sooner you start, the more time you have to stop the damage to your skin. There is a lot of treatments, but I love this slide too so much. I will conclude all the cosmetology in this slide. If you a cosmetic doctor, you will not pass except on these 3 lines. You should put your plan on this. Primary, what's meant by primary? Primary means photoprotection, and Dr. Yasser will cover it very well. Protection, as I said, and thanks to Pharmaceris, because they put photoprotection for young age and adult and face and body and everything you will find it with Pharmaceris products. So thanks for their understanding the meaning of photoprotection, and this is for delaying the aging. A lot of us have a patient who come to our clinic asking me, doctor, I want to delay aging. I want creams in the morning and I want creams at the night. So if you follow me, you will understand what I said now. Is the retinoic acid is important? Yes, because it will lead to decrease the activated protein 1. Does antioxidant is important? Of course, because it will lead to both delayed of the intrinsic factors and leading to decrease of the indirect pathway of UVA. Peptides, this is a new cosmeceuticals again now and have a very important role. Growth factors is important. It will work on the growth factor receptors I mentioned before. If the aging appear, you will play here. You will play here with 3 R's I said before. First R, relax, you will use botulinum toxin. Second R, refill, you will use filler. Third R, rejuvenation, by any means, laser, dermabrasion, chemical peels. All of this way you can treat your patients very well. And photoprotection is a lot, and including the physical protection. And I thanks again Pharmaceris because they mentioned the importance of hidden areas like ears, chest, back, and the neck and feet to put the sunscreens on it. And finally, again, I invite you all for our interesting conference in collaborations with our important societies like MCAS and 5cc. It will be held in September, inshallah, 16 to 18 September, and we are waiting for you to share us our success, and thank you for your precious time, and see you again soon, inshallah. Thank you.
Hello, everyone. I'm Dr. Yasser Gohari. I'm the ICC President 2020. I would like to welcome you all in this nice webinar. And my presentation today is about the photoprotection and the ever young skin. When they asked from me to make a presentation about the sun screens, in about 25 minutes, I told myself it's a very long time for making a presentation on sunscreens. So I started to search on the PubMed for the publications. For example, I searched for the acne vulgaris. I found more than 12,000 publications. But for the sunscreen, I found more than 26,000 publications. It's double the number of acne vulgaris concerning the publication. And also I found a very interesting topic, which is the oral photoprotection, more than 200 publications on the PubMed. So to summarize what Dr. Wael said in his lecture, we have sunlight spectrum, the ultraviolet spectrum, which consists of 5% visible light and infrared. There is a special type of high energy visible light between the ultraviolet and the visible light with wavelengths of 400 to 500 nanometer, which have a harmful effect on our skin. The ultraviolet rays, as we know, it's the shorter wavelengths and consists of ultraviolet A, B, and C. And UVA consists about 85% of the ultraviolet rays, and they present constantly of equal intensity during all the daylight throughout the year. Unlike the ultraviolet B, which fluctuate throughout the day with strongest effect at the noon, and both of them can pass the clouds and smog. Visible light, which is the only part of the sun rays that can be detected by our eyes, and as I told you before, the blue violet range, which is 400 nanometer, which is called high energy visible light, has its harmful effect. How can it harm our skin? This high energy visible light through immediate darkening of the skin and increase the production of reactive oxygen species and increase the expression of matrix metalloproteinases 1 and 9 and increase the DNA damage. The infrared, which is A, B, and C, which like the ultraviolet rays are not visible by our eyes. The infrared has a bad impact on our skin as causing photoaging by generating mitochondrial reactive oxygen species with a following cascades, which leads to increase the expression of matrix metalloproteinases 1 and 9. Also, it can trigger infiltration of the inflammatory cells to the skin, with decrease the number of Langerhans cells and decrease the wound repair. This is a bad effect of the infrared. The effect of the sun, it depends on how much we are exposed to the sun. Too much exposure causes skin damage in the form of sunburn, photoaging, hyperpigmentation, and sun allergies and diseases. As we see, ultraviolet A and B with the high energy visible light can cause to the skin DNA damage, cellular oxidative stress, sunburn, hyperpigmentation, and photoaging. Especially the high energy visible light, which is the blue light, can cause cellular oxidative stress, hyperpigmentation, and photoaging like ultraviolet rays. Now, UVB is important to our skin in formation of vitamin D and the melanin production, but when it penetrates the epidermis, it can cause immediate damage in the form of sunburn with temporary thickening of the skin. Also, it is directly absorbed by the DNA, which is the main cause of actinic keratosis and the skin cancer of the skin. And it can also cause some hyperpigmentation, but the main rule here is for UVA and high energy visible light. The UVA can penetrate up to the dermis, and the main action for the UVA is photoaging, hyperpigmentation, and sun allergies like polymorphous light eruption, but also it can cause indirect DNA damage through causing or production of the oxidative stress. Also, UVA with high energy visible light can increase the production of reactive oxygen species, and our body antioxidant can neutralize them. If there is imbalance between this exposure and the antioxidant effect of our body toward the exposure more, this will cause what's called oxidative stress of the skin. The hazard of the skin can occur in the form of sunburn, which is caused mainly by UVB, photoaging, which is mainly by the UVA through and high energy visible light through formation of the oxidative stress, which destructs the collagen, but also by the direct effect, damage effect of the UVB on the skin. Hyperpigmentation mainly by ultraviolet A and high energy visible light, and to lesser extent to the UVB. Sun allergies mainly by the UVA. And last, the skin carcinogenesis mainly by the UVB, which can cause starting from actinic keratosis to skin cancer in the form of basal cell, squamous cell carcinoma, and melanoma. To summarize the hazard effect of the ultraviolet radiation, we have hyperpigmentation, DNA damage, triggering of inflammatory phenomena, promotion of tumor growth, and collagen destruction with mitochondrial deletion and oxidative stress. But not all the sun rays are hazard, but there is some benefits for the sun rays, like vitamin D synthesis in our skin. And this very nice study I found on PubMed that about mood enhancement, they found that serotonin is affected by the sunlight. So in bright days, the serotonin level is increased, which is known a very powerful brain chemical that is associated with happy feeling. For this impact on the northern hemisphere in the winter, the reduced exposure to sunlight caused to decrease the secretion of serotonin and appearance of symptoms of depression and excessive sleeping, which is known as seasonal affective disorder. How can skin reaction to the sun be influenced? There is some influencers can affect the skin reaction, like the external factor. For example, the 90% of the ultraviolet rays can pass through the clouds, and 80% can be scattered or reflected by the snow, and 25% can be reflected by the sand, and indoor workers are receive less ultraviolet rays more than the outdoor workers, and shades can reduce ultraviolet by 50%, and the most important, that is 60% of the ultraviolet is increased between 10 a.m. and 2 p.m. What about the internal factors that can affect our skin reaction to the sun rays, like skin tone? We all know that fair skin always burn and dark skin always tan. Age, small or children skin and older age are more fragile to sun exposure, and location in the form of sun exposed areas are more prone to sun effect. Oily skin can resist hazard of skin more than dry skin, and skin conditions like certain medications, chemical peeling, laser treatment can increase the harmful effect of the sun on our skin. So how to protect our skin? There is a lot of publication, as I told you before. All these publications are within the year of 2020. Please, everyone now can wake up to continue the most important part of the lecture, which is the sun protection. Now we have systemic sunscreens. They are oral photoprotective products which can do either activation of our endogenous antioxidant system, or they act as an powerful antioxidant to remove the bad effect of the ultraviolet rays over our skin. The oral photoprotection divided into 3 categories: vitamins and antioxidants, dietary non-botanicals, and dietary botanicals. The vitamins included carotenoids, which is a very important pigment in the vegetables. We all know that carotenoids is present in carrots. No, it's the main vegetable is the tomatoes that have carotenoids. It decreases the reactive oxygen species in aerobic metabolism and prevent the photoactivation of our endogenous antioxidant system. The most important one is lycopene. If we intake this one for 10 weeks, we can decrease the dorsal erythema by 40%. Also, it has a very powerful effect to inhibit the matrix metalloproteinase and preventing the breakdown of collagen and preventing skin photoaging. Also, it can inhibit the induction and overexpression of heme oxygenase 1, which is an indicator for the oxidative stress. Beta carotene, which is a very important carotenoid, but its action depends on its dose and the duration. We should take it more than 10 weeks, more than 20 milligrams per day. And there is a skin photosensitive skin disease like erythrobiotic protoporphyria are treated by this beta carotene, and with concern that any heavy smoker or asbestos worker have a high risk for lung cancer if they take the beta carotene. Xanthophylls, and the most important astaxanthin, is non-pro-vitamin A carotenoids that present in fish, and it inhibits the production of lipid peroxides and prevented the UVA-induced alteration of our superoxide dismutase. Also, any expression or any exposure to vitamin A, the carotenoids can decrease the tumor necrosis factor release and inhibit the matrix metalloproteinase 1 expression, thus will help our skin from destruction. The second vitamin is vitamin B3, which is nicotinamide, which is an amide form of vitamin B3, which is important precursor for the coenzyme NAD, which is an anti-cancer vitamin and also decreases the incidence of non-melanocytic skin cancer and actinic keratosis. Vitamin D3, we know that 90% of the vitamin D3 is synthesized inside our skin. Vitamin D3 is important to modulate the inflammatory and the immune response of our skin through inhibition of tumor necrosis factor, cyclooxygenase 2, and inducible isoform of nitric oxide synthase enzyme. And the studies showed that if we expose to the sun for a long time, we can take vitamin D, which will decrease or increase the survival of our keratinocytes after UVR exposure. Vitamin D as important as a free radical scavenger, important in helping our skin after the UVR exposure. But when we make some mixtures of vitamins like carotenoids with vitamin E or vitamin C with vitamin E, this can increase the effect more. For example, vitamin C with vitamin E can increase the minimal erythema dose by 21%. The second group is the dietary non-botanical, like omega-3 and probiotics. Omega-3 is very important in decreasing the sunburn and decrease the effect of especially the long-term effect of UVA on the skin. And probiotics is very important for the recovery of the Langerhans after UVR exposure. The third group is the dietary botanicals, including green tea polyphenols. We all know that green tea is a very efficient scavenger for the reactive oxygen species and act as against skin cancer. And also it can reduce the expression of vascular endothelial growth factor and CD31, decreasing the apoptosis. And it can decrease the UVR-induced erythema by inhibiting the upregulation of the pro-inflammatory metabolites produced by 12 lipoxygenase enzyme. Cocoa extract is very important as inhibit MAP kinase activation and matrix metalloproteinase, so it is useful as photoprotection and prevention of photocarcinogenesis and preventing the decreasing of extracellular matrix. The very important extract, which is the Polypodium locutumus extract, which is present both in Europe and United States. It's a very powerful antioxidant because its capacity as a superoxide anion scavenger and also its ability to repair the DNA. Also, its oral administration can increase the minimal erythema dose by about triple-fold, and it can protect our skin from the PUVA-induced phototoxicity and act as anti-inflammatory by abolishing the expression of tumor necrosis factor. Other dietary botanicals like isoflavones, pomegranate, citrus, rosemary extract, resveratrol, and forskolin, all these protect the skin from the harmful effect of the ultraviolet. Now, the topical sun protection. The idea of the topical sun protection is the filter that present inside this sunscreen, which have a very nice action that it absorbs the high energy ultraviolet rays and become an excited molecule. This is followed by returning to its ground state and release this energy as a low energy for a long time. This is the mechanism of action of the UV filters. The good sunscreen should contain both UVA and UVB filter and broad spectrum one as well. The UVB filters, there are a lot of categories. The amino benzoate, the first chemical filter used, which was the para-amino benzoic acid, but now it is not used because it has a very common photoallergen and photocontact allergen sequelae, so it is not used nowadays. But now we are using the cinnamates in the form of ethyl hexyl methoxycinnamates, which is present in the Pharmaceris sunscreens, which is a very good UVB filter, but it is degraded rapidly, but it acts very fast. So they are using it to work early and be helped by another filters. Salicylates are good for increasing the UVB filters and increasing or decreasing its photodegradation. And here another two UVB filters, which is octyl triazone, which is present also in the Pharmaceris sunscreens. They are the highest photostable one with the octocrylene, which is the safest and effective one. The UVA blockers included the benzophenones, which is a strong UVA filter, but it has a photocontact dermatitis effect. For this reason, Pharmaceris used the diethyl amino hydroxyl benzoyl hexyl benzoate, very long name, but very effective as a high UVA protection and high photostability. And avobenzone also present in the Pharmaceris sunscreens, which is considered one of the strongest UVA filters. And the broad spectrum sunscreens, which are the Tinosorb M and Tinosorb S, both of them are present in the Pharmaceris sunscreens. They have a large molecule, so they don't have any side effect of being systemically absorbed. Also presence of physical ultraviolet filter in the form of zinc oxide and titanium oxide, and both of them were cosmetically unacceptable, but when they became micronized, the cosmetic appearance become more and the action become more appear. Here, the dose of sunscreen is very important. According to the rule of 9, we divided our body into 11 areas. Each area is 9%, and each area needs 2 fingers completely to cover it. For example, if we will cover the face, this is the third of the 9, so it will use only 2 fingertips to cover all the face. What is the ideal sun protection? Ideal sun protection should contain ideal supplementation and ideal sunscreen. Ideal supplementation, as we told before, should contain lycopenes in the tomato paste, vitamin E, C, green tea, and Polypodium locutomus extract, and the ideal sunscreen. We all know that we should search for about 4 things. The first one, which is the SPF, concerning the ultraviolet B to prevent the sunburn. It should be not less than 30 plus, and 50 plus is the highest protection, and also prevention of the photo damage and photo aging, and the pigmentation by presence of UVA filter, and also the degree of protection, whether it is high or very high, and its water resistance. All these filters are present in the Pharmaceris, which is Tinosorb S and Tinosorb M with octocrylene as a broad spectrum filters, and the UVB filter, including the methoxycinnamate and octyl triazone. Both are very good and very stable UVB, and last, the presence of UVA filters, the evobenzones, which is a very strong one as UVA filters, and last, the presence of physical filter. And now the good sunscreen in Pharmaceris contains 8 filters, or it's, I think it's more than 8 filters: 2 broad spectrum, 2 ultraviolet A, 2 ultraviolet B, and 2 physical sunscreen. The type of skin, depending on which type we will use. The oily skin, we will treat it as by fluid or lay or gel cream. Dry skin, we will use cream form. Combined, we will treat it as dry. Sensitive, we will use physical sunscreen. And the children, we will use no chemical filter. And the application should be every 2 hours on the air and every 40 minutes in the water. Thanks for Pharmaceris for their nice sunscreens, and thank you for your listening.